Hi, I'm Dr. Randy Martin, and we're here at the AATS Mitral Conclave 2017, joined by a good friend, a valued colleague, Taweesak from Bangkok, the world's expert on rheumatic
Yes,
mitral
you're
valve
very
disease.
kind to
No,
me.
you are. You have taught us all.
Yeah.
So tell me, what's the burden of rheumatic disease worldwide now?
Yeah, rheumatic is still, to me, is still a big problem worldwide because especially in some parts of the world like the threshold country, like in South Asia, in some South Africa, and Latin America, there's East European country. So it's a big burden and still going on, even if we have some improvement in healthcare system.
So, and do the ages at which patients appear for therapy vary depending upon the region? In other words, younger in Southeast Asia, maybe a little bit older in Japan or other places, or is that not so?
I would say for the rheumatic patient, mostly they're younger compared to the other pathology like degenerative abalo.
Right.
They mostly are younger, although there are maybe more adults or more adolescents, but still younger than the other group.
So that's problematic for surgical approach because what you do might not last them their lifetime. Is that correct?
That is correct partly because I think that we have to say that the ongoing process of rheumatic is real in the younger. But for the more adult, or maybe we can improve the result by getting more understanding of the pathology and improve of the technique and approach in order to completely repair as much as possible. Then we may hope that it will last longer.
So yeah, and I sort of, what I was implying is that a young patient who you operate on, they might face another procedure later in life, whereas an older patient, obviously, you can address the problem. So, Taweesak, you have pioneered really our knowledge about repair of the rheumatic valve. And it's interesting because we think in degenerative primary diseases, too much leaflet, too much mobility. Here we got everything. We got decreased mobility and retracted scar. What do we know about repairing those valves, say in a young patient?
Yeah, that is a truth that we learn by ourselves as well, because we learn from our pioneer in the Western country, and the pathology is just excessive, mobile, but we going back home is restrictive, deformed, and paucity of the tissue.
Right.
How to repair that, that's another story. But it's based on the same principle from we learn.
Okay.
We just have to understand and change the technique more, like it's thick we peel, it's filled we cut and spread it out. And then we remodel it, or we replace with some tissue repair when it's needed. And then we can achieve the same result or quality of repair. It's just a problem, how long it's gonna be. A lot of questions about the durability of the repair. But based on what we learned and improved during recent years, the rate of repair is higher.
Okay.
Durability up to midterm is good.
Okay.
And even if they have something happen, it's still a gradual process that the patient have time to seek help. Unlike mechanical prosthetic valve, it's just sudden and very catastrophic even.
So you've really pioneered and taught us a lot about basically, so if you've got a restricted immobile valve, that what you just said is that you could free that up, use tissue if you have to, extra tissue, neocords, all of that. Is that correct?
Yeah, we employ every aspect. But the major problem in rheumatic is not just the commissural fusion. In the subvalve fusion, subvalve retraction, that we have to resect, spread it out. And if there's really sparsity of the tissue, then we can use the tissue repair and put in the cord if we need it.
Okay.
All of this combine into only one result, one aim, that is to restore it back, both diastolic and systolic function.
If you have to put a prosthetic valve in a patient, and that might be, what would be the type of patient that you would put you'd say, we just can't repair this, we're going to have to use a prosthetic valve. What's that patient look like?
Yeah, that still happen, especially in the very extreme cases. And we still stick to the rule like in Thailand now. If it's under 50, we stick to the mechanical valve. With the modern type, and we hope that we can have a good result in long term. More than that, now our tendency is to use mobile prosthesis because the advances of transcatheter technology that we hope that it can be used in the future.
Okay, and in the young patient, female, who might want to have pregnancies and things, you're going to do everything you can to repair those valves?
Yes, and we try our best, and then we have to say that the rate of repair in this group is very high. It's very close to degenerative now. We can even review it with the autologous pericardium, put a lot of cortex, and then we wait. We hope that we can prolong this until she got everything, like pregnancy, something like that. Then we redo it. It's no problem.
Well, listen, you have done a fabulous job of educating all of us. I've made the statement that, when I was in medical school in the 60s, we saw rheumatic disease. Now in the United States, it's died down, although it's coming back, but you certainly have educated us on not only the right techniques, but how to do them and when to do them. So thank you very much.
Because we learned from you as well, and then we adapted.
Yeah, thank you very much for joining us. Good to see you.
Thank you very much.
And I hope that you'll come back and learn more. Thanks.